All right. I got them right here. What's a vampire's favorite sport? A vampire's favorite sport? Basketball. How do you get a pig to the hospital? How do you get a pig to the hospital? In the ambulance. What's a cake's position in baseball? A cake. The batter. Well done. And then lastly, what do you call a bicycle with a pop tire? Hey, we're videotaping this. Can't use that language. A popsicle. What do you call a bicycle with a pop tire? Popsicle. Okay. I think you guys are wound up too much about this pandemic. It was officially announced that coronavirus is a pandemic. You guys saw that? That's actually real. Stats are in. Okay. All right. All right, moving away from coronavirus. Let's finish out cancer. We're going to talk about tumor markers. Tumor markers. So with tumor markers, we can use these for a variety of different purposes. We can use tumor markers for screening patients or for diagnostics or maybe to track disease progression over time. So what are they? What are tumor markers? Well, these are antigens that are found on a plasma membrane. That's what the PM stands for, or circulating in the blood, within spinal fluid, or it could be found in urine. And these antigens are being present maybe because tissue is creating more of these antigens as the tissue grows. As it mutates and it grows out of control, a lot of these markers start to go up. Okay? So let me give you two examples. Let me give you a male example and a female example, right, to be sex fair. So we've got HER2 and then PSA. HER2 and PSA. HER2, conveniently, is the female one, and it stands for Human Epidermal Growth Factor Receptor number 2. And HER2 is actually typically found in breast tissue on the cell surface. Now, if there's breast cancer, then masses within the breast tissue in females will get bigger, they'll enlarge, there'll be a tumor mass that's growing, that's not supposed to be growing, and so the amount of HER2 expression in that breast tissue will be higher than normal. Okay? So HER2 expression can be a tumor marker to give us an indication about the progress of breast cancer. And let's kind of remember that one for later when we talk about treatments. We're going to talk about cancer treatments at the end of the lecture, and so I'll come back to HER2 as an example. PSA, prostate-specific antigen. Prostate-specific antigen. This is obviously in males, as women don't have a prostate. Backing up, can men develop breast cancer? Yes, they can. They have mammary tissue, but in low presence of estrogen during development, the mammary tissue doesn't develop into glandular structures like it does in females. But men do have the possibility to develop breast cancer. Now, with PSA, with prostate-specific antigen, females do not because they don't have a prostate. Okay, so this is a male-specific one. Prostate-specific antigen. But these are the two biggies. One of the largest percentages of cancer within females is breast cancer, and that's why breast cancer awareness is so high. It's by no means the only one. Colon cancer is pretty high. We'll look at the statistics here in a second. But that tends to be the kind of the big one, the number one for women is breast cancer. Number two, or the big one for men is prostate cancer. Okay. Prostate-specific antigen. So prostate-specific antigen is an antigen that's circulating in the blood, and the prostate manufactures it. And as men age, their prostate naturally enlarges because age is a disease, and the prostate is working harder, and so it gets bigger slowly over time. So in men, I say normal part of the age process, it's very common for an enlarged prostate to be present in men over the age of 50, for example. And every decade it gets a little bit larger, and it starts to put pressure on the bladder. And so men who can't hold it anyways, right? Women can always outlast us as far as having a road trip, right? I mean, I have 5 women in the car when I drive. I'm always the one that's like, does anybody have to go to the bathroom? Come on, I know you have to go. It's about time. We're pulling over. Everyone's going. All right, I'll go too. And I'm like, right? And I'm like running to the restroom. So as the prostate enlarges in men, every decade it gets that much bigger. It puts pressure on the bladder, and now they wake up a couple of times a night and have to go to the bathroom. Okay? That's kind of a normal aging process. But what that means is if you're looking at a graph, well, that marker is worthless. If you're looking at a graph, this is why I bring my own. Try this one more time. I have to edit that part of the video. If you're looking at a graph, okay, and let's say that this is age on this axis, and this is PSA levels on this axis. And let's say at the age of 40 is here, and then we have 50, 60, and then we have 70. So prostate-specific antigen is probably going to do something like this as this patient ages. Question is, if you have prostate cancer or a tumor in the prostate, then you're going to have higher than normal levels of PSA. But what you need to know is you need to have some sort of baseline to know where does that patient fall. So the question is, if this patient is cruising along and then it starts to do this, how do you know if here it's normal, quote unquote, age-related, and where does it kind of start deviating from the graph? And so this is the reason, especially for men's health, but also for women's health, I'll explain the difference. With PSA, because it's so easy, it's a blood draw, right? And so having annual physicals for your patients where you're getting PSA levels so that you can kind of see where is their normal set point on PSA levels so that we can understand, are you just getting older and your prostate's enlarging, or do we have something that we need to be paying attention to with your PSA levels? Does that make sense? Now let's go back to women. Because HER2, you'd have to do a biopsy of the breast tissue. You're not going to do that on an annual basis. And so you're going to be doing self-examinations, and you're going to be doing mammograms on a regular basis. And so right about the magic age of 50 is when all this stuff happens. And depending upon familial history or family history, for females, if there's breast cancer in the family, they might say mammograms are going to start at the age of 40. Okay? Understand the difference between a blood circulating one versus one that's found in the tissue? It's found in the tissue, you have to go get biopsy tissue. So when they do a mammogram and they see a white spot that they're concerned about, and they say, okay, we're going to do a biopsy, they're looking for HER2 expression, and they're looking for histological evidence of what's happening within the breast tissue itself to see if it's benign or malignant. You with me? Looks like I put some little canine friend asleep. Fantastic. All right. So true to that conversation on what these breast lesions look like, this is a invasive ductal carcinoma of the breast. It's the white portion in the middle of the screen that you're looking at. And this tissue is retracted because that lesion is hard and stony right in the middle, and it's kind of bringing the tissue into it. And on palpation, it would feel like a lump, like stony lump. Okay, it would be hard upon palpation. So this leads us to some of the questions along the lines of, what types of mutation lead to cancer, or why does it come about? And so you can see this diagram here on the right where we've got little symbols. And these symbols are, from your textbook. And these symbols are trying to give us an indication of different types of things that can happen from a mutation standpoint. And these different things that can happen may not all happen in one individual cancer. But for the most part, you need a few of them, at least 2 or more, to actually simultaneously happen for cancer to become problematic, like metastatic cancer. Let me explain. This symbol is saying that there's self-sufficient growth signals. So the tissue, the cell, has decided I'm going to grow on my own. I'm going to ignore any kind of growth patterns, and I'm going to do this them on my own. So that would be one mutation. Another one would be they're insensitive to anti-growth signals, and that would be this sort of symbol. This symbol is that there is a mutation that allows it to be extraordinarily invasive. Like maybe it makes extra matrix metalloproteinases. Those are enzymes that digest away the basement membrane to allow the cancer to get out of where it originally was found, okay? And that's this little kind of, it looks like 3 fingers that are kind of, squirming out. This one, the infinity symbol, which is appropriate because this is symbolizing that there's a mutation maybe in the telomeres or in telomerase activity, allowing for limitless replication. Okay, so a sign kind of suggesting that it's immortal, like we talked about on Monday. Here, finally, we get to Max's prized question on angiogenesis, right? So these masses need to have a blood supply. And as they grow, we know that there's necrotic core in the middle because they grow too fast. But one of the mutations that they can generate is they generate extra angiogenesis to allow nutrients to support the increased growth in the mass of the tissue. And you've heard all sorts of anecdotes, like so-and-so had a tumor removed and it was like the size of a grapefruit or a baseball, and it's all in different locations. You're like, what the heck? Like, that is crazy to think about. Okay, I mean, one of your classmates was sharing with me about their grandmother who had a tumor in the brain, and unfortunately she didn't make it, just like my mom. And he was sharing, it was like the size of like a grapefruit, which is huge when you think about it, right? So these masses will grow and they need their own blood supply. And that's this symbol right here. Then this one is a symbol, right? Kind of the cross, kind of symbolizing that they're able to evade death. They're evading apoptosis. So evading programmed cell death, because your body's really good. And we're going to learn about some tumor suppressor genes here in a second. And this is always the point in the lecture where students get confused. So I want to make sure you prepare for tumor suppressor genes. Okay? We have the capability to discover cancer. And our body's been doing it for a long time. And so there can be a mutation where now the tumor becomes non-discoverable by your immune system. And it doesn't get signaled for apoptosis. So as healthy individuals running around in this harmful environment, even though it's a hospitable environment for life, it's still very harmful to us. We all, every day are evading cancer. We're triggering cells that are misbehaving every day and saying, apoptosis, go away. And when that mutation happens of that ability to find them and suppress that tumor, that's when cancer shows up. Does that make sense? That's kind of what happens, is you and I are battling cancer every day, and it's just eventually, as age increases, our ability to find it is compromised, and our ability to detect it and kill it is compromised. Okay? So we've got all sorts of different types of mutations that can take place, and we're going to look at all of them, or many of them, okay? And we're going to talk about it. Now, I'll come back to this slide here in a minute when I talk about how this cancer, in order to propagate, needs a couple of mutations. And there's a slide kind of at the end of this mechanistic section that will really bring this to light. And I'll kind of refer back to this slide. I just want you to remember that there's many different mutations that can happen. Here's a list of them. And you need a few of them to happen all at the same time. So the way I would explain this is, if you've got the ability for the cancer to grow without sensitivity to anti-growth signals, and it just keeps getting bigger and bigger, it's going to reach a critical mass unless it generates a mutation to bring in new blood supply. Does that make sense? Like, it's only going to get so big, and then it's going to run out of energy, nutrition, and it needs a blood supply. So there has to be a mutation in angiogenesis in order to allow it to propagate. And then it's only going to get so big and keep going, and if it doesn't have a mutation to allow it to be invasive, it's never going to leave that space. So do you see how these kind of microevolve? And that's the slide that we'll look at here in a second. But before we go there, let's talk about these oncogenes. So this is a word that always puzzles students. What are oncogenes? So an oncogene is a gene that is mutated or expressed at high levels. That's the definition of an oncogene. It's a gene that is mutated or expressed at high levels. Abnormal levels. They're not normal. They can become a tumor cell. They can take a normal cell and make it a tumor cell, and that gene that is able to do that, that's an oncogene. Now, a proto-oncogene is referring to the gene before it becomes an oncogene, before it becomes mutated. And so, how can these things mutate? And so there's three ways that I want to point out on how these things can mutate, these genes can actually mutate. So a point mutation is simply a single base substitution, and that's what this diagram is trying to illustrate, is just one base is out of sequence. And it's a type of mutation that causes the replacement of a single base nucleotide with some other nucleotide for the DNA or the RNA. This now point mutation inserts a different single base pair in that location. So that's one way it can happen. And you could see, basically, this is almost as if you had a document and you're trying to scribe it word for word, and you miss one letter, or you get one letter off. You're supposed to say received, and you don't put the I and the E in the right order. You flip them. Right, is I before E except after C, right? So it's EI, and you put IE. You guys with me? So that would be a point mutation. You mix up one location. Second way this can happen is a gene amplification. And this is known as gene duplication or chromosomal duplication, where you have a cellular process where multiple copies of the gene are produced, when really, in reality, you only needed one. And it has serious implications, like in evolutionary history, as well as drug resistance capabilities in cancer cells. So it's thought that cancer cells that become drug resistant, we had a question here, I think on Monday, about drug resistance with cancer cells. And so this gene amplification is sort of blamed mechanistically for why cancer is able to do that over time. They become less resistant. Define amplification. That's basically making more than one copy. And then the last one is chromosomal translocation. This is an abnormality where you've rearranged parts of non-homologous chromosomes. So you get a gene fusion that takes place when you translocate two otherwise separated genes. And this is very common in cancer. And so you might have a gene that is translocated, making what we call this chimeric protein or a blend. And now all of a sudden, the translocated gene keeps the replication always on, for example. When before, it only turns on like once every 6 to 8 weeks. Now it's always on. It's like someone left the light switch up. Okay? So the good news is we've got tumor suppressor genes in our body, and there are a whole list of them. A whole list of them. And I'm going to actually require you to study in detail 2. We're going to talk about 2. You're welcome. All right? But there's a lot of examples in your book, there's a lot of examples in the literature of tumor suppressor genes. We're going to talk about P53, okay, or what we call TP53, and I'll explain the difference. And then we're going to talk about retinoblastoma, or RB. And there's a number of other, examples of tumor suppressor genes, like VHL, APC, CD95, ST5. You don't have to write these down. ST7, ST14, and the list goes on. I'm highlighting TP53 and retinoblastoma because I want to hone your studying down, true to what I said in the beginning of the semester, and I really want you to elegantly understand two, so you can kind of see mechanistically why they're so important, why they're so valuable. So the first one that we'll look at is TP53. Now, tumor protein 53, or TP53, this is the gene that codes for the protein known as P53. So P53 is the protein, and TP53 is the gene. Does that make sense? So if we're talking about a tumor suppressor gene, we're talking about TP53. If we're talking about the tumor suppressor protein that the gene makes, we're talking about P53. Does that make sense? The way to remember that is P53 is like protein 53, so that's the protein. The gene is the longer term, is the TP53. Okay? It's nomenclature, but if you're reading your textbook, they'll go back and forth. If you're reading literature, it'll go back and forth. And so I want you to be clear on what the nomenclature is. So P53 is the protein. TP53 is the gene. Now, the problem would be at the level of the gene if it mutates. Because what it normally does, and that's what we're going to talk about in this slide, is it normally monitors stress inside the cell. It is referred to as the central monitor of stress in the cell, TP53. And it's also referred to as the guardian of the genome. Doesn't that sound like a phenomenal Marvel movie title? Guardian of the Genome. You guys can borrow that someday if you want. Just give me some credit at the end. Has a super high turnover rate. It's present in cells in low levels in a non-phosphorylated inactive state. And then when there's DNA damage, it's phosphorylated. And what it ends up doing is it ends up pausing replication so that you have time to make a correction in the damaged DNA, or if it's not correctable, you actually trigger it for apoptosis. So let's look at the diagrams. I know the diagrams look kind of busy and scary, but that's what we're going to see right here. So this is normal activity that happens down here, okay, down the center. You've got, you guys see this happy-looking cell? You guys can see the happy-looking cell? So the eyebrows up here, and it's got two mitochondria. One nucleus is the nose. So this is a normal cell where P53 is normal. The protein is normal. You get DNA damage. P53 binds to the DNA, and you've got sort of a couple of different pathways that can take place, right? You've got a P21, a GAD45, and a BAX. Now, what are some of the things that are going to cause DNA damage? Well, the main one that it responds to, but not the only one, is hypoxia. So if you have hypoxia, you're going to have the opportunity for DNA damage to happen. If you have ionizing radiation, okay, you'll have the opportunity for DNA damage to take place. But any kind of stress to the cell, P53 is going to respond, whether it's hypoxia or radiation, okay, or UV radiation in the form of sunlight, like next week. Some of you guys are going to sunny places. You'll have an upregulation of P53 next week if you're getting suntans or sunburns, okay? And it's measurable. So let me tell you a study that we did once. We were working with a derm company, and they were developing a topical to try to keep skin from aging, okay? And we actually recruited patients in Southern California to get biopsies off of their left forearm. Why did we choose the left forearm in Southern California? That's the driver's side, right? And we take biopsies here, and we were measuring P53 levels in patients, and they were measuring P53 levels in the same patients like 18 weeks after using this sort of anti-stress topical, okay? So next week, P53 levels will be upregulated, probably all over unless you're just driving in Southern California, right? So P53 binds to the DNA. Transcription-dependent and independent effects happen on these sort of 3 gene targets. These are the gene targets, P21, GAD45, and BAX. BAX is the apoptosis gene. So what you can see immediately is if BAX is upregulated and repair fails, then you just trigger that cell for cell death, programmed cell death. But if you've got P21 stimulating a G1 or GAP1 arrest, that's in the cell cycle, then you pause and allow time for repair to take place, and then you resume replication. So you make an appropriate copy. And this is what normally takes place. The other one is GAD45. So either GAD45 or P21 can initiate successful repair because GAD45 triggers DNA repair and P21 stimulates a G1 arrest. Okay? So you hit pause, you take time to repair, and then you allow it to continue and you get appropriate fidelity and replication. But if it doesn't work, repair fails, you use the BAX gene to trigger apoptosis. So that is the normal process. You guys understand the normal process of P53. You might want to circle that middle panel and say, this is the normal activity that we want to have happen with P53. Now let's look on the far right column what happens when it mutates. So now you've got a cell with a mutation and it loses P53. You've got DNA damage, and now your policeman, your central monitor of stress in the cell, is compromised. And so you do not have any dependent genes that are activated, right? You've got no P21, no GAD45, and no BAX. And so you got no cell cycle arrest. You've got no DNA repair, no senescence. That's a word that means to pause, okay? It doesn't stop. It just replicates the mutation. And as it replicates the mutation, you get additional mutations that show up, and they just continue to build. So can you see very quickly how having a tumor suppressor gene like TP53 that gives rise to protein 53, which is your tumor suppressor protein, you lose protection. And interestingly enough, in most of the cancers that we have identified, there's something wrong with TP53. It's one of the main mutations that shows up in so many of the cancers. Not in all, but many. And the ones that it doesn't show up in, it's usually a different tumor suppressor gene. But this is one of the big ones. It was not the first described, but it's the one that's most ubiquitous, and that's one of the reasons I highlight it. Yep. Yeah, it's just damage. Yeah, damage to the DNA, and it could be age-related. Like as the patient ages, their tumor suppressor gene isn't functioning as well because as they gotten older, that part of the genome got damaged with UV radiation or chemical exposure or pollutants in the environment. Okay. Second one, which is actually the first one that was ever described. So every semester I play with the order. Okay, which one do I talk about first? Because it kind of seems like you should talk about the first one first, but P53 is so broadly there in cancers that it sort of gets the first position. This was the first tumor suppressor gene that was actually identified, retinoblastoma. So RB1 is the gene sequence, RB1. And RB1 is the gene that codes for PRB, which would be the protein. PRB. So let me write that down. So RB1 is the gene, and PRB is the protein. Make sense? So retinoblastoma, this is a tumor suppressor gene that has a very similar type of activity as p53. But they are not the same gene, nor are they the same protein. Does that make sense? So they have similar activities. Can you imagine that other tumor suppressor genes may also pause replication? That seems like a good way. Hit the brakes, and let's see if something's wrong. And then if everything's good, then let's keep going. Does that make sense? That's the mechanism. So this does something very similarly. It just does it in a different way. And you have many of these in the body, but we're just talking about two. So walk through this slide. Again, I want to show to you on this slide what normally happens, and then we'll talk about where things go wrong. But what's shown on this slide is the normal process of retinoblastoma. So this slide is describing all of its normal function in you and I in a healthy retinoblastoma situation, okay? And then we have to speak to where the problems are, but it's not shown here. So everything here is normal, quote unquote normal. So you've got two main states of retinoblastoma, and retinoblastoma is sort of this hanger-looking structure that now is surrounding E2F. You guys can appreciate that? So it's kind of like this clip. This looks like an up arrow, the E2F, and hypophosphorylated retinoblastoma, meaning it only has two phosphate groups, it sits really nicely on top of E2F. And as it sits nicely on E2F, it sits down in the promoter portion of the gene, in the E2F site, and then you get all of these other complexes, these histone complexes that kind of bind. And what this does is it prevents transcription and arrests the cells in G1. Okay? Then, after it pauses it and arrests the cells, and you check the integrity of the DNA, and you say, everything looks good, hit the green light, you know, like the stop sign, you know, the traffic, it's like those traffic one-way bridge guys or gals. And it's a stop sign on one, and then it's like a slow on the other, and they just like, that's their job all day long, is like, boom, slow, stop. That's what this does. So this is the stop sign. Then, when it's ready to switch from stop to slow or go, you phosphorylate this with 4 more phosphate groups, and now it goes through a conformational change, and it opens up. As it opens up, it comes off of the E2F, and all of these other blocking histones are gone, and transcriptional activity continues. Okay? Does that make sense? So in a hypophosphorylated state, it blocks transcription and pauses it in G1. In a hyperphosphorylated state, retinoblastoma's activity is blocked, and it allows for transcription or copying of the sequence to continue. Does that make sense? So let me ask a couple questions to make sure you understand. What does retinoblastoma do? It prevents transcription. How? It binds to E2F, which binds onto the promoter site, pauses and arrests the cell in G1, allows for the genetic information to be checked. All right, someone else's turn. How does it continue once everything is ready to go? How does it allow for transcription to happen? You phosphorylate it. Now it comes off of the E2F, and transcription is allowed to continue. You guys make sense? So this is normal activity. Everything on this slide is normal. Now let me ask this question. How would you explain where it could be mutated? Give me some examples of where problems could happen. Yes? It never dephosphorylates. Okay? Wait. Never dephosphorylates? Oh, meaning that it's stuck in its hyperphosphorylated state. Yes, agreed. Sorry, I was thinking of it a different way, that's all. We're saying the same thing, two different ways. So if it remains in its hyperphosphorylated state or it never dephosphorylates, then transcription is left on. Does that make sense? Okay. Pretty clear? These are typically two very challenging topics, is P53 and retinoblastoma. And so that's why I picked two. I picked two that had very similar types of effects, so it's easier to remember. But they're different enough that I feel like you're getting a broad exposure to how mechanistically tumor suppressor genes can work. Okay? Cool? All right. Metastasis. Metastasis. So I want to keep in mind this little figure that we went through previously as we look at this new diagram, which is kind of crazy to think about. So this diagram is showing a primary tumor up top, and then all of a sudden you're getting something gnarly happening at the bottom. So let's talk about what's happening. So up top you got a primary tumor, you got a transformed cell. Now you guys know what that word means. It's transformed, so it's behaving very differently. And you've got excessive growth. It metastasizes, it breaks through the basement membrane because it's invasive. It starts to migrate, and it moves into, say, a blood vessel. This is a blood vessel. As it moves into the blood vessel, it clumps. Yeah, it might actually get some platelet adhesions that take place. It sticks to the surface of the blood vessel, and then it extravasates out. So it's got to digest through this basement membrane again. It had to digest this basement membrane to get in. It had to digest this basement membrane to get out. And then here, now it's a secondary metastatic tumor. And this is how tumor cells metastasize. This could be a lymph vessel. This could actually be a body cavity. It could be like the peritoneal cavity. It's not a blood vessel, but you can appreciate, like if it's colon cancer and it breaks through the basement membrane and moves out of the colon and into the abdominal cavity, then it can spread to other abdominal organs. Does that make sense? Once it gets into the bloodstream, where this secondary location or this secondary metastatic site happens, or what we call a secondary met, it could be close by, it could be far away. It's probably going to be something that's vascularized. So, for example, if, let's say this is in the colon, yeah, I mean, this is where I always get nervous because I might have picked the one that somebody emotionally is connected to, okay? But let's say this is the colon and it breaks through, and now it could go to liver, or it could go to bone, right? If it's in the lung, let's take my mom. It went from lung to brain, and then we took care of the brain, and we were trying to treat the lung with targeted chemotherapy, which we're going to talk about. But we believe that it probably metastasized into other places, like bone. Right? Her hips were kind of bothering her, so it probably made it to her bone. Okay? Do you guys understand kind of mechanistically how it does it? Okay? Strategically how it does it. So let's look at the steps. It invades the surrounding tissue. It uses these things called collagenases, matrix metalloproteinases, and other types of proteases. Anything that ends in ase is an enzyme. And enzymes are proteins. So these are proteins. That's why this is a matrix metalloproteinase. Okay? The word protein is in this one. The MMP, so here's one you can write down. MMP1 is a collagenase. Okay? MMP12 is an elastase. So MMP1, another name for it is collagenase. MMP12, another name for it is elastase. It breaks down elastin. Collagenases break down collagen. So if your basement membrane is made up of collagen and elastin, or protein structures, you need these enzymes to break it down. So they start making extra enzymes. Okay? Then they penetrate into the lymphatics or the blood or into a body cavity or into the lymph, and they're transported to a secondary or a tertiary location, and then they enter and they grow. Question? Yes. That is correct. So the question is, these mutated cancer cells are the ones making these enzymes. That is correct. So they mutate to be able to make enzymes that maybe they never made before. Or they mutate, to develop a new blood supply. And then the next mutation is one where it happens where they make extra enzymes. And again, it's kind of a chance thing. Like the mutation may not be valuable for the cancer the first time, but if it's an active cancer, it has time to continue to mutate. And that's why they always say early detection is so important. Because if you detect it early enough, you might be able to catch it before the mutations have gotten very aggressive. Because the more aggressive the mutations get, the more dangerous the cancer can become. Okay. It'll become a little bit more clear on this microevolution slide that I'll show here in a second. So if you guys can do this in SI or at home, it'll give you a sense of how well of a handle you have on the material. Like if you can describe the development of a malignant neoplasm, and you include terms like normal, dysplastic, in situ, and invasive, and you can walk us through, maybe throw in there's some mutation with a tumor suppressor gene like P53, and this is what's happening. And that then leads to this, which leads to... If you can do that, that should demonstrate to you that you have a pretty good handle on the material, okay? So this is sort of like a self-check homework assignment for you guys over the next, week and a half. Make sense? And if you stop and pause after you do that, like maybe record yourself, and then you listen to it, you'll be like, wow, I sound pretty smart. Like, look at all those really cool words that I just put together in a paragraph, right? Like, there's a lot of, like, if you explain that to mom or dad, they're going to be like, I have no idea what you're saying, but clearly your tuition is worth it. Okay, well done. All right. This is a liver that's studded with metastatic cancer. So you can see all these metastatic sites. Liver is a very common location for metastatic cancer to go. Because why? Why do you think that is? It's a filter. It filters basically almost all of your blood flow from the venous side. So if there's cancer floating in the blood over on the venous side, likely the liver is going to trap it, and it'll get stuck there. And so, true to this topic of blood flow, and going back to our schematic diagram of all the different types of mutations that can take place, let's talk about specifically this one of angiogenesis. And Max asked the question on Monday, and this is the slide I was alluding to. So what these tumor cells can do, and this was really popularized in the scientific literature by an individual named Judah Folkman. Dr. Folkman was a physician, and he passed away, not from cancer, from heart disease, but he was like one of my heroes in the literature when I was in graduate school. Not because I was doing cancer research, but I read a lot of cancer research, and this is kind of how a lot of these fields cross-pollinate, is he was looking at how elegantly cancer developed a new vascular supply in order to survive, in order to grow. And so he's the one that elegantly characterized these budding blood vessels that would move towards a tumor mass because the tumor itself was manufacturing angiogenic growth factors, like vascular endothelial growth factor, or VEGF. And as it makes these growth factors that are angiogenic, it encourages these blood vessels to bud out and bring in a vascular supply to support the growing tumor. And so his thought was, well, if that's the case, what if I delivered to a tumor an anti-angiogenic therapy? He was the first one to describe it in the literature, where let's starve the tumor. We'll inject the tumor with an anti-VEGF or a blocking agent to these growth factors. It'll get to a critical mass and it'll stop and it won't be invasive. It was pretty revolutionary, and it led to a lot of anti-angiogenic therapies. And in the early days, shark cartilage was a huge topic of research. I mean, I didn't do this, but, and this wasn't Folkman's work, but this is after Folkman. A lot of people were doing shark cartilage research, and I asked the question, why were they interested in how shark cartilage forms? Why did a lot of cancer researchers become suddenly interested in shark cartilage development? It's actually the opposite. Cartilage is relatively avascular. And so understanding how cartilage develops, like in a shark, without a blood supply, they could learn new ways to combat angiogenesis and transfer it over into cancer therapy. Does that make sense? It's just sort of a historical trip down cancer research lane. Now, question? Cartilage has low vascular supply. It's not necessarily avascular, but it's generally considered to be non-vascularized or avascular. Really, cartilage has two areas. There's what we call avascular cartilage or non-vascularized cartilage, and then there's cartilage that's actually poorly vascularized. And so we call it red and white cartilage. But most shark cartilage is just white cartilage. It's avascular, no vessels at all. So, I mean, what I was interested in is using the opposite of Folkman's work, and that's what I was studying. So I was researching how to promote angiogenesis for myocardial infarctions, where patients were losing blood flow to the heart. So I learned all I could in the cancer anti-therapy world, and I was trying to apply the reverse in cardiac therapy. So that's why I read a lot of Folkman, because he was kind of one of the first fathers of anti-angiogenesis research, from which we learned a tremendous amount of angiogenic research. And so I was kind of doing the opposite of him, but in cardiac infarctions. So colonal proliferation. This is what I've been alluding to during the lecture that we would get to, is this concept of microevolution. So what I want to walk you through is, you've got a normal cell here, you've got some sort of carcinogen that induces a change, okay? And this carcinogen induces this change, and now you've got this tumor cell that mutates, and it's color-coordinated red, so that you can see that the red is a metastatic mutation. And it doesn't mutate once. If the carcinogen still is there, or the mutagen is still there, then it's possible that it'll continue to mutate, okay? And so it mutates again, and it develops sort of this pink coloration, which is a mutation that says it doesn't need as many growth factors to grow. And then it mutates to, and these two are both favorable, so they continue. It mutates to this variant of purple that doesn't give it any benefit, so it dies out. But this light blue one gives rise to this ability to be invasive. And that's helpful for it to propagate, so that stays. And then this sort of baby blue one becomes hidden. It's a mutation where it's non-antigenic, so it hides from the immune system, so it's not triggered for apoptosis. And so what you have at the end is a mass or a tumor that has multiple mutations that have happened over time. It's highly metastatic, it's growing, it's invasive, it's aggressive, and these are typically metastatic malignant cancers that you hear about that are scary. And this is the process that I was alluding to, where you need to have multiple mutations in order for this cancer to achieve what it's after, which is to propagate and continue to cause problems. Question? How fast does it take to mutate on a normal basis is the question. It just depends. Certain cancers will mutate very aggressively, very quickly. Other cancers will take years to do it. So, a popular one that has a very high mutation rate, that's very invasive, that goes rather quickly, is glioblastoma. And so many of you probably had heard of Senator John McCain, who passed away from a glioblastoma. So that's a glio cell, right? It's a cancer cell in the brain. And these glioblastomas are very aggressive. They grow very, very quickly, and they're very difficult to surgically operate because they end up growing, instead of into a mass, they grow out into like a starfish configuration. So when the neurosurgeon comes in, they literally have to cut out sort of like this starfish or polygon shape in 3 dimensions, and it's very difficult to get the whole thing. So like glioblastoma is probably the one that mutates very, very quickly. A lot of patients that are diagnosed with glioblastoma, it may be 3 to 6 months until they're gone. It may be as long as 18 to 24 months before they're gone, but most glioblastoma patients won't last beyond that. Does that make sense? And there are other types of cancers that are very slow, like thyroid cancer, for example. It's pretty slow. Even within prostate cancer, some prostate cancers are very aggressive in certain patients. In other patients, they go into remission, and it's manageable for many, many years. So it just, unfortunately, it just sort of depends. But there are a couple like thyroid, which is slow, and glioblastoma, which is very fast, and then everything is kind of in between. Yeah. Question is, we'll talk about some of the treatments at the end. The question is, can you do chemo and then do surgical? Oftentimes, it's the reverse. They'll come in surgically, and they'll take it out, and then they'll follow up with radiation or chemotherapy to try to get the areas maybe that they might have missed. Okay. Why? Well, surgery is usually pretty tough for patients, especially if they have cancer. And chemotherapy is tough on a patient who's already weak. And so after chemotherapy, the chances of them being a surgical candidate are even lower. So they usually try to do the surgery first while you're theoretically as strong as you're going to be for a while. Then they'll follow up with chemotherapy. Does that make sense? Yeah. So this is sort of a summary slide of what we've covered so far. And I think this summary slide is another great tool, a study tool, to provide you with an opportunity to see how well can you put together all the different pieces of the puzzle. Okay? So you can see up here you've got a normal cell up top, and we've got all sorts of different stresses. We've got things like radiation. We've got things like chemicals, things like viruses. I haven't yet heard of the coronavirus leading to any type of lung cancer. Okay? You're like, what? Well, viruses do cause cancer, and infections can cause cancer. But that hasn't happened yet. It's not in the news. It doesn't look like patients are, but it's early. We don't know what's going to happen 5-10 years from now. All right? Not that coronavirus hasn't ever been here, but this is like a totally different variant that's super aggressive. But chemicals, radiation, and viruses that we see, chronic infections or chronic inflammation, they can cause mutations that occur to the normal cell. And that causes DNA damage if there's not successful repair. And so in this box here, right, is where you would have the ability for P53 to work normally. Well, if you've got DNA damage and you have failure of DNA repair, then it propagates. As it propagates, you've got inactivation of tumor suppressor genes, like retinoblastoma or TP53, for example. You get alterations in the genes that regulate apoptosis, like BAX doesn't show up as a downstream signal. You lower apoptosis and you have unregulated cell divisions. This clonally expands. Clonal expansion is this right here, right? You get this microevolution that takes place. Now you've got all these different mutations like angiogenesis, escaping from immunity. All these additional mutations, the tumor progresses, becomes malignant. Basically, this ball right here is this portion of this flow chart, and now you've got an invasive and a metastatic cancer. Okay, so this flow chart kind of summarizes this whole process of what happens with cancer. Okay? You guys follow? Yeah. Like encapsulate the cancer mass? Yeah. I don't know. It's a good question. I haven't seen anything like that. I imagine I mean, it's possible, but I imagine surgically what they've decided to do is if you're going to get in there, why don't you just take it out versus try to encapsulate it? But it's an interesting idea. Yeah, question in the back? Question, is it true that if you surgically cut cancer, does it make it so that it replicates faster? So I haven't seen any evidence to prove that, but what we do know is when you go in surgically to remove cancer, there's a high likelihood that you may not cut it all out. And so what they'll do with a cancer mass is they'll come in and they'll surgically resect the cancer mass, but they take healthy margin. They take healthy tissue around it just to have a high level of confidence that they got it all. So if it's an abnormally shaped cancer, it's harder to determine where the margins are. There might be some leftover cancer cells that are present, and that's where they'll follow it up with post-surgical radiation or post-surgical chemotherapy. Okay. Then the next piece is it responding to the surgery, or is it just that it's continuing to mutate anyways? So it's hard to know the answer to that, right? But some patients have surgery and they don't ever get better, and the cancer becomes more aggressive. And likely, in my mind, it's because it's continuing to do this, whatever's left over that didn't get taken care of. Matrix metalloproteinases secreted by tumor cells are important for which feature of malignant tumors? Angiogenesis, anamplasia, invasiveness, apoptosis, or differentiation? Invasiveness. Very good. Invasiveness. So let's talk at the last little portion. We got two sections, kind of incidences and causes of cancer, and then we've got treatments. Looking at the time, we'll probably get through a little bit of the incidence and causes, and then we might have to come back after spring break and cover up the treatments, okay? But I want to compare and contrast. The slide's a little outdated, but it is still accurate with respect to the percentages, and you can see the differences between men and women. So prostate being the big one in men, and breast being the big one in females. But you can see that, melanoma and thyroid and lung, kidney, colon, all of these are not, they're sex blind, right? They're going to hit both men and women in almost equal populations. Okay? But from an awareness standpoint, you can kind of understand why we see a lot of publicity around breast cancer and prostate cancer. And so many of you that have loved ones that might have passed away from like a colon cancer or like a non-Hodgkin lymphoma or something else, the only reason, it's not that people don't care, it's just the numbers are bigger in the other categories, and that's why there's more awareness there. Does that make sense? Types of carcinogens. Types of carcinogens. So we've got all sorts of different types of harmful agents that can attack us. And these carcinogens, in certain cases, can become mutagenic or mutagens when they cause an alteration in our genetic information. So if you've got a mutation that happens like within the germline, then it's going to be heritable, right? It's going to be passed on down. But if it's a mutation that happens within an adult lineage, then it's just happening in that particular patient. And so the difference here would be if there's a mutation that happens in patients where now all of a sudden there's a predisposition to developing breast cancer in women in that family, likely that's a germline mutation that's inherited. Okay? And we're starting to get more sophisticated where we can screen for that. And that's why you see, like in Hollywood, you'll see individuals that proactively test positive and say, you know what, I have a high likelihood at some point in my life of developing breast cancer, and so these women are electing for double mastectomies even though there's no cancer. Okay? Do you guys understand what I'm talking about? So some patients now are proactively or prophylactically taking measures, extreme measures, because they understand that there are mutagens that have taken place long ago in their germline, and they've inherited that particular trait. Now, there are other things that can cause mutations in you and I, and this is where we're going to hit the pause button, but I just want to lay it out for you. So chronic inflammation, infection, whether it's viral or bacterial, and environmental factors all have been demonstrated to lead to cancer. Okay? So we'll leave it at this. How does chronic inflammation contribute to cancer? Well, if you've got an uncontrolled inflammatory situation in a tissue, you've got all sorts of chemokines, cytokines that are being released because of this rampant inflammation that's chronic, and that rampant inflammation can cause extra reactive oxygen species in the tissue. That causes oxidative stress that can cause damage to the DNA. And if that happens, say, over a 40-year period of time, then you could actually have a mutation that could lead to cancer. Does that make sense? So we see like ulcerative colitis patients have a higher likelihood of developing colon cancer. If there's inflammation in the colon for decades, there could be a mutation within the colon cells in their genetic information and cause colon cancer. Chronic unmanaged asthma, higher incident rate of lung cancer. These inflammatory cells that are there and in a smoldering inflammation situation are making all these reactive oxygen species. And the COX-2 increases, and that is associated with all sorts of different types of cancers, including colon cancer. Okay? So there is a connection between viral infection, chronic inflammation, and even environmental stresses in developing cancer. We're seeing that firefighters, I don't know if you saw this in the news, firefighters actually have a higher incident rate of developing cancer, presumably because they're around a lot of carcinogenic agents that are burning. That's part of their occupational hazard. Okay? So we'll pause there, have a great spring break, and we'll come back here kind of at an odd point to pick up, but I'll kind of back up a little bit to get us back after a week and a half, okay? Be safe out there, guys. Have a great spring break. Have some good time off.